Thank you for introducing me. Good afternoon, everyone. I'm Jung Kim, pediatric cardiologist. I work at Bucheon Sejong Hospital. It's so honored to present and share about this topic, all of you. I will introduce 4 cases about how to manage branch pulmonary artery stenosis after surgery. Please let me know if you have any question or comments at any time, even during the presentation. So case 1, 17-year-old female patient who initially diagnosed with TOF with angulated hyperplastic LPA. Initial chest X-ray, chest CT before TOF repair noted infundibular stenosis and small MPA and angulated LPA, but relatively sizable both PAs. She underwent TOF repair at 6 months and transannular RVOT widening and MPA and LPA angioplasty to fix angulation was performed. In immediate post-op CT scan shows further aggravation of pulmonary. Post-op CT scan shows relieved obstruction of RVOT, but mid portion of LPA decreased the dimension, as you can see. Serial follow-up lung perfusion scan shows further aggravation of blood flow discrepancy, right-left ratio exceeded 2. So it is indicated for pulmonary artery intervention. So follow CT scan revealed mild stenosis of mid MPA and focal stenosis at proximal LPA, as you can see. Indications of pulmonary artery intervention include pressure gradient more than 20 millimeter mercury across the region of stenosis and increased RV pressure to approximately more than 2/3 of systemic pressure and relatively pulmonary blood flow discrepancy between the 2 lungs, with one lung having less than 35% of the total flow of lung perfusion scan. So the last indication was for our patient. So we decided to perform intervention for LPA. And the first cath was performed at the age of 6 years. Angiography shows LPA stenosis. And balloon angiography on LPA using 10 and 12 millimeter balloon was performed, but repeatedly recoiled LPA after BAP, so it was ineffective procedure, we thought. So what is your next step? Here are several options. Please tell us and discuss freely. So number 1 is end the procedure and follow up closely. Number 2 is perform BAP using larger balloon more than 14 millimeter. And number 3 is perform BAP using cutting balloon. And number 4 is end the procedure and consider re-intervention within 3 to 6 months. And number 5, stent insertion on LPA immediately. And number 6 is surgical LPA angioplasty and also supravalvular widening.
Number 5.
Yes.
So Sejong, what would you do?
Actually, I want the LPA stent more earlier time.
Okay.
Yeah.
Dr. Shingo Kasahara.
Yeah.
Excuse me, can I ask a question on one thing? And that patient has that PDA before the surgery?
Not exactly.
So what that the neonatal period?
It's a relatively good pulmonary valve size. It's like pink TOF.
But in the surgical science or surgical some things about that narrow segment is that angulation. What's that angulation? The PDA tissue or some the push up to that any another?
I think that is related to the technique, surgical technique. Maybe at that time we fixed completely the angulation of the LPA, maybe. Yeah.
Historically, we struggled with that problem in early 90s. And most of the institutions, hospitals solve the problem with their own solution during the 1990s. However, in this patient, pre-operative CT shows LPA is hypoplastic. Not so, I don't think it is mainly by kinking, but maybe LPA coarctation may be a underlying mechanism of the hypoplastic LPA junction. So,
Yes.
do you have any? We couldn't hear.
Hello.
Mic on, please.
Just to ask, when you balloon dilation, what is the pressure? What was the
Maybe,
pressure?
This,
Evercross, maybe the somehow usually dilate any balloon to the rated burst pressure. So maybe I think 8 ATM or something like that.
Now, the reason I'm asking because to me it looks like a kinking, and likely that one is compliant lesion, and it means that you don't really need a high pressure to make it big. But my personal preference for this particular case would be I just do balloon interrogation, not fully inflated by the pressure, but just using my hand to see whether how compliant that area is. If that's so compliant, it means that either bigger balloon will not work. You need to stent it. But if somehow you have the tight waist and you need the pressure, then you may try to get a pressure, high pressure balloon or cutting balloon whatsoever. But this particular case, I do agree with Jay that likely that we need to stent.
However, we can observe the behavior of a deflating balloon.
Oh, yeah.
To judge whether it is a tight the stenosis, circumferential stenosis or the kinking. And even though it is, whether no matter what is the mechanism, kinking or the circumferential stenosis, we can put a stent to solve any problem.
Of course, but with a tight lesion, maybe it's need further consideration whether the stent going to fracture or how big of the balloon you're going to put.
Agree. Yeah.
Yeah. So I think
Frank?
that's a good case that we should continue, please.
Frank?
Actually, it's a good point you're making, Warcon. Sometimes it could be a fold or a kink, but actually, once you put your wire in, the stiffer wires, you can tell if it's a kink because the wire will change the orientation already. So that's another clue, even without the balloon.
Yeah, thanks.
Dr. Sakamoto, what do you have any? Please.
Yeah, thank you very
unmute.
much.
Yeah.
Yeah, thank you very much for inviting me. So sometimes the Wi-Fi condition was not good, so sometimes I could not get the real information. But so I would like to check the condition of the around LPA. So is there any surrounding organs, including the bronchus and others? At the time, so sometimes we will have a difficulty to make a dilatation of the stent. Is there any some?
Jung-Yoon, would you show the CT scan and whether
Yep.
there's some airway or something is?
Yeah, there is no concern about other structures. So we have to safely insert its stent or larger balloons, anything, no matter.
Thank you very much. So I also agree to use the stent, but so together with growth, body weight growth and time, so we will redirect the stent. At the time, the enlarged stent can make something. So before inserting the stent, we have to consider that. And if something outside surrounding issues exist at the times, our surgeon can contribute to something. I think so.
So stent, but which is the stent size is very important. So we have for a long time we have some problem in using the large size stent in Korea. But the only one was the jaw stent. We even didn't have a Parma stent. So according to the Frank's review journal in CCI, the stent can be divided into several kinds of the according to the maximal dilatable diameter. So large size stent, medium size stent, usually the manufacturer, the recommendation is up to 8 millimeter, but that can be dilated up to 12 millimeter. And the large size stent is refers to the maximal diameter is 16 to 18 millimeter. So at least the large size stent should be used in this case. What do you think, Jung-Yoon?
Yes, I agree with. But at the time, we have only a small stent here.
Medium size.
Yeah.
Usually iliac stent, that is the maximum dilatable diameter is 10 to 12. That's
Yeah.
a problem for a long time in Korea.
Yes.
Yeah, move to next part.
Back to my PPT. So the narrowest portion was measured at 5 millimeter, and distal part is 11 to 13 millimeter. So we decided we performed stent insertion on LPA using 10 millimeter express vascular LD stent, 10 millimeter, and 25 millimeter length. Follow-up lung perfusion scan after stent insertion was improved. Follow-up cath was performed to folder dilation to LP stent and evaluate hemodynamic of her heart. The result shows severe supravalvular stenosis with pre-PR, as previously noticed. So follow-up CT scan shows focal stenosis and mid-MPA with a mild RVOT aneurysm, as you can see. So RV angiogram shows aggravated supravalvular PS and free PR. The pressure gradient between distal MPA and RV was 16 millimeter mercury. So far, we was indicated for surgical supravalvular widening and surgical PVR. But I think here are a few things to consider before surgery. I would like to hear the comments from audience and panels and moderator on this point. First, is it necessary to perform LPA angioplasty in this surgery? Because our last lung perfusion scan shows 1.6. And is it indicated? And if you do the surgery, how to do? Do you have any comments?
So panelists first.
Because concomitant surgery, so LP
Dr.
stent.
Shingo?
Yes. I think that this stent little bit protruding into the main pulmonary artery, is that right? So the left PA stent.
A little bit, I think.
A little bit, yeah.
Yeah, is that a problem or not?
A little bit grow, but up to 9.5 millimeter, so it's too small. Follow-up somatic growth inspection. So anyhow, we have to maybe increase the size of when she was grow up, but exactly,
No,
I don't know
I think that-
exactly
No,
the follow-up.
it means to that that's left side stent little bit protruding to that main
No,
pulmonary
no,
artery.
Yeah.
not
That
at all.
because of
No
that,
problem,
some,
yeah,
of the concern about that some flow turbulence of that left pulmonary artery or something about that some tissue inside the pulmonary artery or something.
Actually, the stent is a slightly distal portion, not MPA protrusion state.
Yeah, mid
Right.
LPA position.
So however, well, even though it is protruded, we can remodel the stent. Using some compliant balloon, oversized and the longer than the stent. Then if you rapidly inflate the balloon, then inflation in the balloon at the both sides may compress the balloon length and shortening the length, which frequently decrease the pressure gradient because the narrow portion is shorter, even though it couldn't be dilated further. So we can remodel the stent. That is one of the important features. After shortening the stent, then some part of the native pulmonary artery distal to the stent may grow further. as time goes by? And also, is this the patient is present case or case in the past? Now we have the melody valve, and the RVOT, the supravalvular PS, could be overcome by the RVOT stenting and the melody valve implantation.
Yeah.
So, is the patient in the past or
Yeah, past.
Actually, in the
past?
past,
Yeah, past.
When we didn't have
if she's
the-
now problem, we can do the under stent and melody stent, but it's the 10 years old.
Yeah,
10 years
yeah.
old. Yeah.
Okay. Then maybe Dr. Sakamoto, in this case, this patient had the supravalvular stenosis, which is significant peak-to-peak systolic gradient was 60 millimeters of mercury. So the patient required the RVOT surgery. Then what would you do to the LPA stent? Would you remove the stent or cut the stent and the patch augmentation, or what would you do as a surgeon?
Yeah, thank you very much. So my Wi-Fi condition was not good. I could not get the exact information, but so supravalvular stenosis together with the LPA stenosis, with so stenting, and so we got the information from the lung about the long cutting together with the patching, the very bad result. And maybe the cut and the patch is not so good because of the form of the LPA. So form of the LPA after cutting is not so good to make LPA form again, even by surgery. So usually I remove the LPA stenting. However, so we are carefully do the LPA stent removing,
However,
especially on the. Sorry.
this stent was from the LPA junction to the hilum. So
Yeah. So usually we have to take care of the remove, especially on the deep side, just hilum. So if we cut into the LPA hilum to a lower lobe PA, at the time, so deep patching is not so easy to do. So just several minutes before the hilum, I try to remove the stent.
Yeah.
okay, so Frank, are you there? Frank?
Here, I'm here.
Yeah, Frank. I have the question to you for this matter. So you told in your talk that longitudinal, the cutting and the patch augmentation of the stent may increase surprisingly the reintervention rate. However, because I experienced several cases who needed early reintervention after such a approach. However, it is because of the infolding of the stent at the cutting edge. If the LPA diameter, this is the medium-sized stent. Maximal dilatable diameter is 10 to 12 millimeter, which is significantly smaller than the adult size of the LPA left branch pulmonary artery. So even though it requires reintervention, if augmented by patch, we can balloon to increase the correct the infolding of the stent after surgery. And then if we later, if we have a larger size stent, for example, larger size stent, then we can solve the problem without any redo surgery. So what do you think? Even though requiring reintervention is not the end of the world, we can manage it by intervention anyway. So what do you think?
Well, I think the problem is that you don't have the large stent at this time. So you put in a smaller stent to get the kid out of trouble, and at some point you have to do so. Of course, in this situation, when you're in surgery, you got to somehow get rid of the smaller stent so that you can make room for a potential larger size later on. So I think in this situation, you're stuck. You have to get rid of that stent. And I think that in a situation like this where you fillet it and put a patch in, you're right. You know you're going to have to go back in, but at least you know you've created a situation that allows you to put something in that can get to adult size once you have available large size stent. Now, I think the main point that I was trying to make is not to say to the surgeon, don't do those things, but if you had a large stent in there, then I would say leave it alone, because if you take it out, you're going to have to go through the trouble putting another one in. And I've had plenty of that experience. But of course, this is a little different because you do have a small stent. You don't have much of a choice. So I do think that in this scenario like this, your first goal is to get rid of the maximal diameter, which is too small. And if you think that filleting it and putting a patch in is what you need to do that, that's okay too, because it's not the end of the world to go back in to fix it later on, providing you have a big stent at that time.
If you have a bigger stent, then what do you think?
Yeah, so if there was a bigger stent in there that I know can get to adult size, I would try to talk my surgeon into leaving it alone. Like I said, there's been plenty of times where the surgeon took it out or did different things, and then I'm back in the cath lab within 6 months, and I have to put another stent in to fix the stenosis. So
and also
that's what I would do.
We can unzip using the ultra high pressure balloon.
Well, yes, you can theoretically, but it's kind of unpredictable. Even though with the best of intentions and you're going 1 millimeter, I'm hoping you can unzip it. It's not always predictable. Once you get it to shrink to a napkin ring, it's impossible to break at that point.
Yeah. Napkin ring formation, if once we make a napkin ring, then it couldn't be unzipped.
Yeah, exactly.
Okay.
So I have a question, Professor Choi and Yoon. Do you have any technique for unzip the stent? Because it's too unpredictable.
It is very well documented, actually, using the ultra high pressure balloon. Frank, you can explain your experience unzipping.
I find that the way to unzip it is not so much to use a really big balloon and try to overpower it, because all it does is make it shorten up to be a napkin ring. You have to go 1 millimeter at a time, get it to whatever max, and then go super high pressures 1 millimeter at a time, so that at some point one of the links unzip. But if you try to use a very big balloon to overpower it, it will just shorten out. It would just become a napkin ring. At least that's been the trick. But even though, like I said, I've had this where I just can't break it no matter what, and you're stuck, and then you have to go to surgery. Again, that's why I try not to use those small stents. And I always tell operators that if you put a stent in, you own it. You own that stent for the rest of the patient's life, whether you see that patient or not. But we inherit patients from other people where a small stent was put in, and it was good for many years, and then now the baby's outgrown it, and you're stuck.
So unzipping is usually requires the ultra high pressure balloon, the 18 ATM or higher, and don't make a napkin ring. If as I told while I'm talk about the remodeling of the stent, if you use the longer and larger balloon, then stent can compress. Then it forms like a napkin ring. Then it wouldn't be unzipped. It couldn't be unzipped. So similar the length of the balloon, ultra high pressure balloon, and not so the oversized, and increase slowly. And unzipping, there are also some bench testing for unzipping. So
yeah, actually at the time we in Korea there are no ultra high pressure balloon as like
Yeah, yeah, of
Atlas
course,
balloon,
of
so
course.
we don't have
In the
any
world,
option.
we didn't have at the time.
Okay, go back to my
Yeah.
PPT.
Yeah.
Can we move? Yeah,
Just a moment.
Okay.
yeah.
I have a mention about your procedure because it's up to your stent. I think that stent is pre-mounted 10 millimeter stent. I experienced after redilation with 12 millimeter balloon, the stent fragmented and embolized. So very worry about the fraction, the fragmentation. So it's not a palmate stent. So you
Yeah.
very careful for the redilation.
Yeah, express stent. I don't like that stent for pulmonary artery. Yes, I think the property of the stent is not good for pulmonary artery. And also the one last thing is that if you make a napkin ring of the stent, then take some wait for some time, then it would be better to remove at the next session operation.
Okay. So she underwent surgical PVR and RVOT reconstruction and also total removal of LPA stent. So LPA and RVOT angioplasty with a bovine pericardiums at our patients. That is immediate post-op CT scan. It shows widened RVOT and LPA, as you can see. However, one year follow-up, post-op follow-up CT scan showed markedly decreased proximal, proximal LPA like pinpoint, which was only 1.6 millimeter only. And a significant change in LPA size can be seen on a CT performed immediately and after surgery and 1 year follow-up surgery. It's remarkable change. So, and we did fourth cast for severe LPA stenosis. In MP's angiogram shows severe hyperplastic LPA, as you can see, is nearly atretic. So 1.2 millimeter only size. So we performed BAP on LPA sequentially using 4 millimeter Sterling balloon and 7 millimeter Imada balloon. So I have a lot of questions, but looking at the progress so far, what is your next step? Here are several options I have and or other opinion, other guys.
Which
panel.
stent do you have?
We have only which stent. At the time, we have only medium size or larger balloon.
At the time, we have just the EV3,
EV3.
and
EV3?
Yeah, just
Yeah.
we have
EV3 is good.
EV3.
So what size of the EV3, which size?
EV3 size
millimeter.
is just 10 millimeter, but in bench test, we can redilate the 15 millimeter. Yeah.
50 millimeter, EV3 off-label. Yeah, actually never
Okay.
imported.
Just a moment.
I want value stent.
Dr. John?
Yeah, I have a question. Why do you remove the stent? Well, totally remove the stent. Actually, after stent insertion, most of the endothelium is almost damaged. Although stent is buried in the endothelium. If you try to remove all the stent, it can make some damage to endothelium. So it can be a problem. Why do you remove?
Yeah, so actually, I removed the stent totally. So at that time, our conference, pediatric cardiologist recommend totally remove the stent.
Okay,
So
Somo
I
is not here, so you can say that. Yeah, okay.
So in our hospital, I do not remove the stent.
Right.
Just a cutting stent and then spray the stent. And so it can make almost doubling the size of the stent. I mean with the stent
Yeah, yeah.
spreading,
Right.
Yeah.
and then do the patch angioplasty.
That's
Do
what
not
we usually do.
If you want to extract the stent, it can damage all the endothelium, so it can be a
Right,
big
right.
problem.
So that's what we usually have done. But in Frank's data,
Yeah.
it may require more frequent the reintervention. So that is a problem, but it's not the end of the world, I think. So we have many cases, so we have to
Yeah, move on.
proceed. Thank you, Dr. Jung.
I'm sorry, I want to ask Dr. Shingo and Sakamoto, do you have any idea about the total removal of the stent in these patients? How should we do the remove the
From the LPA junction to the hilum, yeah?
Yeah, right. Yeah. Is there any another way to prevent this event?
Yes, I just asked that question at first. And because of that, some risky of that stent all removed. Because of that, probably put in a stent 9 years old, and then to that remove to 6 years
6 years.
old and put in a stent, and then 5 years already has been passed. I think that in that situation, is a stent is probably inside the wall. So and Dr. Tego said too that all remove that stent is some problem of that intimal injuries. So I think that Frank recommended to not to do that patch enlargement, but I think that partially remove to that stent and then put in some patch, and then probably immediately after the 2 months or something, and put in a large stent.
So the problem is that the transected or some partially removed or trimmed stent may have some the property to recoil, then may cause a restenosis. Then still we can intervene deal with those kind of reasons. So would you proceed,
Yeah.
Dr. Kim?
Yeah. Back to my PPT. Yeah, we put the stent again on the LPA, EB3 10 millimeter and 17 millimeter lengths. So then we did fifth cath for further dilation on LPA stent. This is. So 6.7 millimeter diameter increased 9.5 millimeter. So which is follow-up CT scan. So shows a hyperplastic LPA still, but stent without in-stenosis, and we have so we discussed all things, so we follow up on outpatient clinic now without symptoms. So we would like to discuss this point, this total remover stent, introducing the following case. Case 2, 6-year-old male patient diagnosed with PA-VSD PDA. So this is this is pre-op CT scan. It shows pulmonary atresia, but relatively good morphology of both PAs, as you can see. He underwent total repair of PA-VSD, so RV to PA conduit using fresh autopericardial roll, 8 millimeter, at the age of 16 days. The immediate post-op CT scan shows still hyperplastic branch pulmonary arteries, especially RPA. The post-op 5-month follow-up CT shows RV enlargement with the RVOT aneurysm, mild focal stenosis of distal portion, distal MPA, and severe stenosis at proximal RPA, and relatively good LPA. So which is best way to treat the stenosis of the bifurcation site? Number 1 is BAP only. Number 2 is stent insertion immediately. Number 3 is surgical PA angioplasty again. Which is your...
So panelists, Soik-chan.
Actually, I want the post-pulmonary ball angioplasty, but I think it's not effective, so we have to consider pulmonary stenting.
Yeah. So you know it's not fair. You know.
So I don't want to comment because I know this case.
Okay. So Dr.
I just
Kasara, yeah.
Yes, I just asked the question, is Chanha, why do that the 16 days the pulmonary arterial patient, it's a free pulmonary regurgitation, it's even a small PAs. I think that the free pulmonary regurgitation probably to that severe pulmonary hypertension in 16 years.
It's a nationwide question from Korea.
Actually,
Sorry to that, just asking.
in some patients, even though small pulmonary artery, but after a total repair, we've seen some patients improving pulmonary artery size. Yeah, but in these patients, not the case, right?
Sabu, any comment?
Yeah. Thank you very much. So anyway, so stenotic right PA is very severe. And maybe, so in my institute, we try to make a right PA reconstruction using a pericardial model together with RVA candid with cusps, maybe. Maybe. So anyway, so I don't know exactly why this right PA is small. So aortic arch, ascending aorta is compressing or not?
Not compressing, because the patient's
Not compressing.
preoperative CT showed us some relatively small RPA, right?
So Frank,
Okay.
what is your opinion in this patient? Of course, stent, right?
I say that last sentence again. I had a hard time hearing you. Can you say that one more time?
So what is your opinion, the treatment plan for this patient? I think you can treat this patient by stenting. So I'm sure, but I would like to ask your opinion.
Yeah, no, I have a bias, and I find that the stenting works best for me. But I thought what Shingo said earlier was important. When you have these complex stenoses, you have to make a plan that spans a long time. And so he had mentioned earlier that when you go to surgery and you do something, preemptively, I would just say the kid's going to come back to the cath lab in 2 months. You schedule for them so that you're already knowing that. Now, if everything works well, you go there and you find things aren't so bad, and that's great. But more likely than not, you're going to find something that you're glad that you were able to intervene early before it gets worse. So in this case, I would definitely stent and plan out the longer term follow up, and just have schedules. Just keep doing this over time until you're confident that the restenosis does not happen. I can't give a good answer for why the RPA is also so small. I don't understand that part. Now, can I ask, you must have the larger size stents now, right? This was earlier before, correct?
Yeah.
Okay.
Yes. So would you proceed?
Yeah. Okay, we prefer Sung-Ho Kim's patients. Sung-Ho Kim preferred the stent insertion, so we stent insertion into MPA to RPA. So 7 months old, the first cath was performed. We BAP on RPA with a 6 millimeter balloon, Armada balloon, and then also required and non-effective procedures. So. Yes. We measured the size like this and plan the stent positions. And then stent insertion of MPA to RPA using EV3 10 millimeter size and 27 millimeter length.
So length looks longer for me. So it is because of the availability, right?
Yeah, I don't know exactly.
Shorter stent wasn't available. That's the reason, frequent reason in Korea.
In my experience for Sung-Ho Kim,
actually the Sung-Ho Kim wants the MPA to RPA, like RVOT stenting. Yes. So
RVOT stenting?
Yeah,
it's like
RVOT
stenting. Yeah. So you can
Because-
see the next slide. Yeah. Okay.
Maybe question to Frank. So in this situation, Frank, if you have this stent, can you cut it to customize it? And if yes, how? Thank you.
You're
muted. You're muted.
Sorry about that. The only stent that I found to be consistently safe to cut and minimize balloon rupture is going to be, it's the Genesis stent with the sigmoidal hinge.
Okay.
All the other ones, I can't consistently keep it to prevent it from pinhole ruptures. So I think the EV3 will have the same problem. Now, the EV3 stent is actually very low profile. And I wonder whether in a situation like this, rather than cutting it, folding it so that you don't have the sharp edges. But if you fold it, you're going to need a bigger sheet. So I don't know whether whether this kid can get. I've folded stents as well in the past, but usually I find that cutting the genesis works better because I can keep the profile of the sheath better. But for the EV3, it's a pretty flat, thin stent, so you can fold it if you're worried about the edges.
Sorry, Frank, a stupid question to you. So normally you fold inside or outside? Am I outside, right?
I fold it outside, yeah.
Okay, thank you.
So
Just to make sure I understand correctly.
the reason why the Sungho is intending RVOT to RP stent is this is the kind of open set or hybrid stent. So so that he could open the side
Right.
side branch.
Because if we stand if we stand in just only RPA or LPA, it make the object side another side of stenosis.
Of course,
so
of
we
course.
don't want we want the MPA to RPA or MPA to LPA stent, and then leave only side branch.
The open the gel the LPA. And if it doesn't work, you can put another stent, just like a Y stent technique. Yeah. Okay, the smart decision, I think. So would you carry on? Yeah.
Back to my slide. So in jail, the LPA with balloon angioplasty also successfully using 8mm balloons. So post-op procedure, 6 months follow-up CT scan shows improved RPA stenosis and also well-developed peripheral pulmonary artery vascularity. So, and he has progressed PS, RV enlargement with a free PR. So we end up needed surgery. So past. We have a lot of discussion about this. So we have performed, we underwent pulmonary angioplasty in different way. The stent partial remover with an angioplasty with a fresh autopericardium. So this is 2-year post-op CT scan shows that we can increase in size of both size PAs and also keep the size and not shrink any stenosis at all. So we think the Changari really loved these techniques recently.
This time worked. Right. Thank you.
But Sung Kim want to total remover of stent is preferred. Is more successful to keep the pulmonary artery stenosis, artery vascularity. So, which is better? I don't know, but Changari want to like this.
Okay, we have 2 more cases, yeah?
Yep.
Okay.
So the next to case 3 and 4 is case comparison for discussion and timing and method of management for branchial PS after surgery in early infancy. Ahead of discussion, I will introduce briefly case 3 and 4. So 5-year-old patient diagnosed with PAVSD. So this is summarized of case 3, a lot of history. Pre-op CT shows big brick-like MPA in hypoplastic both PAs and tortuous PDA course. He underwent total repair of PAVSD at the age of 20 days. So this is post-op 4 months follow-up CT. It revealed increased diameter of MPA, in both PAs, but however still noted significant stenosis distal MPA and branching LPA os. You can see. So case 4 is also a 5-year-old male boy patient diagnosed with same disease, PAVSD. And pre-op CT scan shows short, small segments and MPA, and just with adjusted ductal stenosis, of proximal LPA and a hypoplastic of both PAs. He underwent total repair of PA-VSD at the age of 9 days. So he underwent a post 1 month follow-up CT scan revealed a significant LPA stenosis and mild distal MPA stenosis. So this is comparison of the morphology of PA before surgery. So this is a comparison of morphology of pulmonary artery after total repair. Quite similar morphology of PA stenosis, I think. Then, what would you do to increase pulmonary blood flow effectively in the early infant period? So in case 3 and 4, we try to solve this problem with different approaches, surgical and transcatheter. So first, in case 3, this is case 3, the first cath performed at the age of 5 months. PA angiogram shows distal MPA stenosis and both PA junctional stenosis. So we did multiple times of balloon angioplasty on MPA to LPA using 4 and 6 and 8 millimeter balloons. The procedure were, we think, partially effective on both PAs and distal MPA. So RV aorta ratio dropped from 1 to 0.65. So what is your next step? One is repeated balloon angioplasty LPA and MPA within 3 to 6 months, and number 2 is stent insertion on MPA to LPA, and wait and consider surgical PA angioplasty later. In this case,
do we have EV3 stent also at the presentation of this case?
Yes.
Yes, stent. Yeah, so
yeah, EV3 we have.
Dr. Kasara and Dr. Sakamoto, surgeon's opinion.
I think that at first that the PA plasty the surgically, and also some pulmonary valves needed the competent. I think 2 things to that good pulmonary artery tree, even in these cases.
Dr. Sakamoto.
Sorry, so I couldn't get the real information.
Okay.
Yeah.
Okay.
So-
would you come to the microphone? And Frank, well, what is your choice in this case?
You know, if there is a lot of, if the valve needs to be replaced, I always find that, you know, I don't mind working with the surgeons in the OR too. So if the surgeons, again, this is a team decision. If the surgeons feel that they can do a good PA plasty and repair, put a competent valve in, I'm good with that. Again, a lot of this is decided on based on what the surgeon feel he can do. Now, I've also had the situation where the surgeon, if this patient has had multiple manipulations in the branch, there's going to be a lot of scarring. And my surgeons always worry about damaging the recurrent nerve. So a lot of times if it goes to the hilum, he would say, can you put the stent in the OR and then we'll put a valve in. So I've done that too. So again, it really depends on how the surgeons want to work with it. Now, if the surgeon says, you know, if all decide that we don't need to take care of the valve at that time, then I would certainly put a stent in.
Okay, I have a question to you.
Yes, sir.
If these patients, before the repair, the Chang Lee is famous for neonatal repair for everything, TOF, for pulmonary artery VSD, he can do, but I think in many countries in Asia, we prefer the PDA stenting or some palliation. If the patient has a pulmonary atresia with VSD, there are increasing data from the PDA stenting. What do you think? Before the initial palliation for this patient, would you put us at the would you perform the PDA stenting or some other?
Well, again, depends on your surgeon. You need to tell them frankly that what will happen, you know. But for me, if we put a stent in, a PDA stent initially, and somehow it may take to redilate it, maybe one or two times, you know, along the down the road before completion of the repair. So with that, if the surgeon okay, you know, we will go for stenting. But if somehow the surgeon said, well, I don't want to, you know, take the stent out in the future, then let they decide. But one thing I would like to share. So once you put a stent in, especially in babies, that length of stenosis won't getting expand. It means that if there's short stenosis or, you know, small branch stenosis proximally near the stent, it's not that difficult for the surgeon to take care of that when the patient is getting older. So this is what I've learned. Yeah, so I think there's a pros and cons once again. And my surgeon, by the way, they prefer stenting. So that's why we do that.
We usually stents in these small babies, the palliative for the palliative purpose. Smaller and softer stents, which is not so difficult to totally remove. So
yeah, for example, in Malaysia, you know, the policy there, they will do removal stent before 6 or 8 months after implantation.
yeah.
But for us in Thailand, we will leave that for maybe years, not just 1 or 2 years, but maybe even longer than that. As I said, we put 4 millimeter stent initially, and somehow if the patient is outgrowing, and then we redilate it or put 5 millimeter or 6 millimeter inside, just to, you know, expanding more time for the surgeon to do Rastelli. Again, I think there's no right or wrong answer, but that's the thing that you need to talk with the surgeon.
Actually, I want to know in these patients is good for the PDA stent or not?
So, I'm so sorry.
Yeah, back to the slide. I want to see the CT scan.
Yeah, pre-op CT scan.
Back to my slide.
Actually, previously I had a chance to discuss with Dr. Mazeni Alvi, who is one of the having largest experience of PDA stenting in complex conjunctival disease. His answer was previously that there are some limitations, but now in the CSIAP, the Bangkok, so it seems that nearly no limitation with the advanced technique.
You know, not really true, Sejong. Sorry to say that, but like this particular case, it's very long and, you know, more than 2 curves of the ductus. So it means if you want to tackle this, you need to have not just 1, but maybe 2 or 3 stents, you know, connecting together. And then most of the time you will stretch the PA because of that. You know, it's curved, but when you put the wire in, you put a stent in, you stretch everything. It means that somehow you're going to stretch the pulmonary artery too. So that will mimic the flow in the future or growth of the PA in the future too. So in this particular anatomy, I personally will ask a surgeon to help.
Okay, I agree. However, tortuous itself is not a contraindication because we can straighten the PDA. So the PDA course could be quite different after the stent the placement. Of course, in this very complex PDA, maybe different from the usual decision making, but in the most of the cases, that is also, I would like to emphasize that would be one of the treatment option. Okay.
So 3 months later, we perform cath for stenting. We prefer stenting. Stenting. And pressure gradient between proximal and distal MPA was 67 millimeter mercury. As you can see, this is a limitation point, endpoint. And we measured and decided the location of stent. And then stent insertion on MPA, nearly RVOT stenting, MPA to LPA, using EV3 8mm size and 27mm length. Then we BAP and on gelled RPA very successfully. But I think after stent insertion, the pressure gradient RV to MPA at the time, but mild pressure gradient between LPA and mid-stent, and RV aorta ratio dropped from 1.15 to 0.67 successfully, but I think proximal stent tip positioned in RVOT muscles, it may become a problem. This CT scan comparison of CT performed before procedure and 1 year after a stent insertion, it can be seen that peripheral pulmonary artery vascularity is greatly improved, I think. So now let's move on case 4. The first cath was performed at the age of 2 months. Selective RPA angiography shows severe RPA stenosis with a hyperplasia, and you can see very hyperplastic LPA also. So we balloon angioplasty performed using 5 and 6 balloon effectively. And also severe LPA stenosis with a hyperplasia, we did balloon angioplasty on LPA 4 millimeter balloon. And final angiogram shows slightly increased post PA size and also no definite multiple peripheral parenteral stenosis at this time, I think. Post-procedure 2 months follow-up CT scan shows minimally improved LPA, but still severe stenosis and no growth interval change of distal MPA and junctional stenosis, and no interval change of RPA or stenosis. So he underwent second cath for BAP on both PAs. It shows still severe both pulmonary PA junctional stenosis and diffuse both PAs, hypoplasia. So what is your next step? I suggest 3 options here. Please give me your opinion freely, whether you agree with this opinion or not. So as mentioned earlier, unlike case 3 and case 4 was treated so honestly with surgical angioplasty of both PAs. So I passed the discussion. So he underwent RVOT reconstruction, distal MPA and LPA, and RP angioplasty with fresh autopericardium at the age of 5 months old. This is immediate post-op CT scan shows improved distal MPA stenosis and post-PA junction stenosis, but you can see newly developed distal post-PA stenosis below hilar portion. You can see. 3 months after second operation, third cath was performed. Selective RPA angiogram shows mid-RPA stenosis, with pressure gradient of 48 millimeter mercury, and also we BAP in mid-RPA using 6 and 8 millimeter balloon, but it was not so effective. So, and also selective LPA angiogram shows severe hypoplastic LPA with pressure gradient of 42 millimeter mercury. Diameter was 1.5 millimeter, and we did BAP on LPA using 3 and 5 millimeter balloons. So I think it was partially effective. So this is follow-up results were compared after each treatment. Case 3 is for transcatheter treatment, and case 4 is surgical treatment. So case 3 is developed a peripheral pulmonary artery vascularity was quite good, whereas severe proximal stent stenosis due to RVOT muscle and in-stent stenosis developed. And case 4 improved distal MPA and both PA junction, but diffuse both pulmonary junction, pulmonary artery branch PS, especially below hilar portion and with a suspected multiple PPS. So that is what is next step for diffuse both pulmonary artery junction stenosis in case 4, as you think. Case 4 is this patient. How about next step treatment?
So Jung, you know the answer. So
Yeah, actually everything, I know everything, but actually the case 3 and case 4, the attending is different.
Yeah, I
approach
think
is very,
so.
very different technique.
Yeah, yeah.
And at case 4, the attending is slightly conservative strategy. So the attending want the balloon angioplasty just stenting, but I recommend the stenting.
Yeah, balloon angioplasty, I don't think there is actually the repeated balloon angioplasty could be effective in many regions, but if you don't planning the multiple times of repeated balloon angioplasty,
Yeah, right.
then maybe stent should be better. What do you think, Frank? In this kind of lesions, the balloon angioplasty would work without stent?
No, I don't think so. But in general, my principle when I see these sort of very diffuse stenosis, that I try to put a stent in the proximal vessel first, and I've found that sometimes when you put a bigger a size proximally, you get more flow, and then actually the distal part actually gets bigger on its own. So not to say that you don't need to do anything else later on, but you put the stent in proximally, you bring the patient back in 2 or 3 months later, take another look. Sometimes the vessel's deeper and gets bigger. And then of course, if it doesn't get bigger, then you work from the main branch to the lobar branch. And rarely I've gone to the segmental branch many years later, but I start proximally and I move distally. So I think when you get to the lobar branch, you don't have to use the big stents anymore. You can use your medium-sized stents, but I always try to start proximally.
Yeah. However, very rarely, some patients shows the peripheral pulmonary stenosis without respond to any treatment. Some patient, I have experienced in my life 2 cases of such case, stenting, balloon, the cutting balloon angioplasty, high pressure balloon angioplasty, any kind of the intervention didn't work, and the progress to a severe intrapulmonary stenosis. However, it is very, very rare. The most of the cases, I would agree to the Dr. Ing's the principle, work up from the proximal region and to the distal region. The intervening the distal regions may demanding procedure. Okay, Dr. Kasahara, would you add some comment or some?
Yes, I agree to that, Frank, because of that the proximal dilatation is needed. But in such the good work to the proximal dilatation, competent pulmonary valves.
Yeah. That's very
because
important.
of that the pre-pulmonary regurgitation is dilatation is pressure is very low.
Yeah.
So I think that good pulmonary artery development or growth needed to that the competent pulmonary valves.
So if the two options, one is a competent pulmonary valve or continuous flow.
Yes.
Yeah.
Yes, exactly.
Okay, back to the slide. So at the age of 1 year, 9 months, first case performed RP angiogram shows newly developed multiple PPS and pressure gradient RPA proximal to distal was 15 millimeter mercury. And LP angiogram shows newly developed multiple PPS, pressure gradient between LPA proximal and distal was 15 millimeter mercury. We performed multiple times of BAP on the segment of both pulmonary artery branches. And next, at the age of 2 year, 5 month, 5 cath also show this diffuse both pulmonary, both PAOs stenosis and distal multiple PPS, and pressure gradient is too high. So we decided to perform stent insertion, so bilaterally. So we performed stent implantation on RPA EB3 10 millimeter size on a proximal. So that's the final angiogram. And also selective LP angiogram before stent insertion, and also placing the stent in the landing zone and check the position again through the angiogram, and stent was deployed successfully, I think. So this is finer angiogram, shows the white, both PAOs, but still hyperplastic and stenosis of both distal part, as you can see. Post-procedure 5 months follow-up CT reported that LP stent was narrowed, luminar stenosis and me2 distal segment, and suspected severe stenosis in the LP hyaline part, and RP stent was patent and minimal in-stenosis and proximal in-stenosis. So 9 months after last procedure, 6 cath was performed. So you can see newly developed pulmonary, both PA, mid and distal severe stenosis, in-stent stenosis, and multiple PPS, and poor peripheral pulmonary artery vascularity were seen in this angiogram. We did BAP on both PAs, but not much effective. So follow-up CT shows relatively improved RPA vascularity compared to the first CT, but still multiple PPS and poor LPA development, and also aggravated post-in-stent stenosis. So he presented failure to thrive, and echo shows severe PR with the RV enlargement, and both PA junctional stenosis and moderate TR, and pressure gradient of 19 millimeter mercury. So compare with case 3, secure pulmonary blood flow in the early period can improve peripheral pulmonary vascularity and prevent multiple PPS. So what is your opinion about this? But previously, Professor Ng said early intervention is important, so I think it's passed. So Dr. Chang Lee has a surgery in this patient. So we underwent RV to PA conduit placement with Contegra supported 18 millimeter, and RPA LPA stent maybe transection longitudinally, maybe the picture says that, and LPA angioplasty with a fresh autopericardium and with a distal part, and bovine pericardium and proximal part, and RPA angioplasty with a bovine pericardium, and also RV muscle resection. So after that, good pulmonary valve motion, no PSR, and no, we think echo by echo, no significant peripheral PS, and also decrease the amount of TR amount, and also we estimated peak pressure gradient is 20 millimeter mercury. So we kept the medication as aspirin. So this is the follow-up chest X-ray. So back to the go back to the K3 when the stenosis became severe degree. So as you mentioned, as I mentioned, the CT scan follow-up angiogram shows good pulmonary artery, both PAs, good growth of both PAs, but severe proximal stent stenosis because of RVOT muscle, because of protrusion, because of the stent. So he underwent RVOT stent total remover and LPA os widening, RV2 PA conduit using Contegra 14 millimeter, and at the age of 2 years. So this picture of surgery during RVOT stent remover, as you can see, that the stent is completely epithelialized on the RVOT wall, making it difficult to remove it. It seems to damage the vessel intimal layer quite a lot. So immediate post-op CT scan shows improved previously RVOT stent and improved the previously stenosis in LPA, but however, newly developed diffuse narrowing of RPA, as you can see. So we, one more follow-up CT reported MPA aneurysmal change and diffuse narrowing of RPA and slightly aggravated post-PA junctional stenosis. Follow-up echo revealed aggravated conduit aneurysmal change because of progress PA bifurcation stenosis and diffuse narrowing of RPA. So what is the best way to treat stenosis of this kind of bifurcation site stenosis? I think it is important. So surgical post PA angiography or BAP plus or an PRN stent insertion on both PAs, bilateral stent insertion technique.
Actually, this is a trifurcation stenosis, I think.
Yeah.
Yeah. So, Frank, what is your choice?
Yeah, I agree. This is more of a trifurcation stenosis, and I would, again, in conversation with the surgeons, I do this as a team to say, if he wants us to delay time for the next conduit changeout, I would put double stents in and make sure that the stents straddle that trifurcation point. I've made mistakes in the past where I would put stents right up to the homograph, and of course, there's still a residual stenosis just proximal to the stent. So I've learned that at this point, you straddle across it and make sure the stents straddle both ends of that narrowing.
Okay, thank you. Dr. Kasahara?
Yeah, I'm at the same situation about that, just waiting because of that next time to that replacement with that RVPA conduits. So Shanghai, I'm so jealous of you because of that many cardiology and help you. I think that Shanghai is that I'm very jealous.
Okay, Dr. Jung? Well, what do you think? What is your option, personal option?
Actually, I want the stent, bilateral stent, because the patient very young, so the valve function is not so bad. So we have to wait. If possible, we have to wait for the PVR. So at the time that we have to reduce RV pressure, so I recommend the pulmonary stenting.
So the Frank showed us many times for the stent techniques, including V stent technique and the kissing technique and tandem technique, many techniques. So this is a trifurcation stenosis. So I think a tandem stent technique or the kissing technique would be the two options. What would you prefer?
Actually, I want for
kissing.
Kissing.
Yeah, kissing is easier, and the tandem stent technique is the another option. But we need a large size sheath to put the both stent in a single sheath, and maybe we don't have such kind of a large long sheath, and also the branch the LP or LP branch is also hypoplastic, so tandem technique itself doesn't yield enough the outcome, I think. So what do you think, Frank? You are the teacher of all of us.
Well, this kid is weight 14 kilos at this time, right? Or something like that. And so again, we have access to the Vallejo stents, so that the Vallejo stents that are mounted on 9s and 10s go through a 7 French sheath, and those can go up to even 20 millimeters if you need to. Of course, when you get to that size, the radial strength is not that high. So I think a 14 kilo kid can handle 2 7 French sheaths if you have the Vallejo stents available.
Yeah, kissing technique, yeah.
Actually, we have no.
You mean kissing technique? Yeah.
We don't have a paleo stent.
Okay. We don't have paleo stent, but even in this 14 kilo the child, if the surgeon want to use the conduit for 5 or 10 more years, we can put the 2 iliac stents up to, which can be dilated up to 12 millimeters.
Actually, the valve is contegra and not reinforced state. So contegra is a problem because sometimes the valve is dilated.
Yeah, dilated. Yeah, exactly. Yeah. Okay. Any other the opinion, Warakan? Do you have anything to make a comment on these cases?
Sure.
Okay.
Okay, back to the slide. So we, at the age of 2 years, 7 months, first cast we built the post-PA junctional stenosis with a good peripheral bed. At this time, we did BAP on the post-PA only because we planned the bilateral stenting, but easily slipping of balloon, so stability not confirmed. So we did not delay the next procedure, next cath. So also follow-up CT scan more aggravated trifurcation site stenosis and MPA aneurysmal change more aggravated. So the third, 3 years old, we decided to try to perform simultaneous bilateral PA stent insertion again using long length balloon. So check both PA by angiogram and 2 stent was positioned at the landing zone, and then we check the position by angiogram also. So at first, the RPA stent was deployed at cover RPA os and to the mid RPA using EB3 8 millimeter to 27 millimeter length. Then LPA stent was deployed at the LPA using EB3 10 millimeter, 27 millimeter length also. But as you can see, LPA stent protrude into MPA, which interfere RPA stent. So the RPA stent was a little bit crushed. So we did simultaneous bilateral PA stent ballooning at the end of the procedures. Finer angiogram shows widened both pulmonary artery junction, but still LPA stent protrude into MPA and interfere RPA stent os, even though simultaneous bilateral stenting ballooning lessly. So after procedures, I thought a lot of this procedure. First of all, is it this patient suitable for bilateral PA stent? But it's a suitable, as you told me. So if patient suitable for this patient procedure, was it the best position for the bilateral PA stent in this patient? Patient? Patient, Professor Che?
Yeah, my comment is that this is the not V-stent technique, not the kissing technique. It is in between the V-stent technique and the Y-stent, the kissing technique. I would prefer kissing technique in this patient. And the reciprocal, the crushing of the opposite side stent is a rule when you are doing this kind of procedure. So simultaneous ballooning and the simultaneous deflation, even though you try to do that, the timing is not exactly, you don't have the very accurate to simultaneously working two assistant. So it may be sometimes you need to readjust the size of the one side of the stent. So I think it is reasonably done. So what do you think, Frank?
I think, it's more like a V orientation. I try to almost make it a X. So where the two are, in other words, the two stents, rather than contacting at the most proximal parts of the shape as a V, I rather make it as an X because then overlapping because
technique,
the issue is not so much now, it's when you have to go back later on that becomes harder because then you go through the side of one and you can't get to that. So when I make an X, the two orifices are farther apart and gives me more opportunity to get back in later on.
Yeah, exactly. Yeah, back to my slide. So progress PA stent stenosis and progress moderate TR and pressure gradient of 68 millimeter. So the CT scan shows that CT scan shows LPA stent protrude into MPA and mild ISR, intimal growth, and superiorly overwrapping of proximal RPA stent. So it made crushed and jailed proximal RPA stent, which caused severe in-stent stenosis. So angiography shows severe in-stent stenosis, as you can see, and both stent. So we can see, sorry. Oh. Yeah, we stent insertion, in-stent stent insertion in RPA, the hardly selected RPA stent, RPA. And then we have to select also LPA stent, but we failed. That's exactly what Franklin and Dr. Che said. Not entered LPA stent, passing wire, and only passing throat strut. So failed LPA stent pulmonoplasty. So more progress and more severe PR because of severe both PA stenosis, and also progressed RPA and LPA stenosis progress aggravated. So we performed next surgeon during short-term follow-up. Echo and CT shows that result. So we decided open cardiac surgery to solve this problem. At the age of 5 years, only the 3 years later, we underwent PVR and RVOT reconstruction, Gore-Tex tube graft replacement of RPA, the cut, and patch angiography of LPA Gore-Tex patch without completely removal of the stent. Longitudinal, maybe longitudinal excision. So follow-up chest X-ray. Follow-up echo shows no significant PSR and both PA colorizing without significant pressure gradient, and decreased the TR amount with pressure gradient of only 19 to 25 millimeter mercury. So he is doing well after surgery, and mom says eat a lot compared before surgery. So that's, I summarized to ask panelists, but we discussed all of this discussion points. So thank you for your attention.